Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. Today's forum is about accountable care organizations. Accountable care organizations, or ACOs, are groups of providers responsible for the quality of patient care and its costs. Medicare offers two pathways for ACOs, the Medicare Shared Savings Program, or MSSP, and ACO models within Medicare's Innovation Center. By January 2026, 14.3 million Medicare beneficiaries were cared for by ACOs, and up from 13.7 million in 2025. As ACO participation grows, so do CMS's initiatives and providers' questions about model structure and future changes. Today, we welcome Emily Brower, the president of the National Association of ACOs, and Sean Cavanaugh, Chief Policy Officer at Aledade. Before Aledade, Sean was the Deputy Administrator and Director for the Center for Medicare, which manages the Medicare Shared Savings Program, and he was also the Deputy Director for Programs and Policy in the CMS Innovation Center, which manages the other ACO models. Welcome, and we're excited to hear from you today.
Thanks, Jim.
So, Emily, let's start with you. Could you please introduce yourself and talk a little bit about how you got to this point in your career?
Sure. Thanks, Jim, and good to be with you all today. So I'm President and CEO of the National Association of ACOs, the largest member governed organization for providers participating in Medicare ACO models. Although our members do much more than that, they participate in value-based payment models across all segments and populations. But what brings them all together and what they rely on NACOs for is to share learning in order to advance outcomes for the people they serve and to collectively influence the payment models that Jim mentioned, both the Medicare Shared Savings Program and models coming out of the Innovation Center, or CMMI. So we have close to 500 provider organizations. I used to be one of those members before I took over the role as president and CEO. So I have spent most of my career leading provider groups who are in total cost of care payment models, population health, clinical delivery models, both at the individual provider group level, the provider network, and then at clinically integrated networks as part of Trinity Health National Health System, but always with the goal of supporting those independent providers who are doing everything they can to improve the health of the people and the communities they serve. So really glad to be with you all together and talk a little bit about that work.
Thank you, Emily. Sean, could you tell us a little bit more about yourself and also about Aledade and what it does?
Sure, Jim. And thanks again for inviting me today. So first, Aledade is a physician-led public benefit corporation and a national leader in value-based care. We help primary care organizations deliver better patient outcomes and thrive financially by keeping people healthy. Through our ACOs, over 3,000 primary care organizations in 46 states and DC are sharing in the rewards of improved care for over 3 million patients. And specifically, Aledade supports these practices through advanced analytics and insights, technology, coaching, policy expertise. And as Emily referred to, all of our ACOs are in the Medicare Shared Savings Program, or CMMI model, but they also do a lot of value-based contracting outside of that with MA plans, commercial plans, and in some cases even Medicaid MCOs. And Aledade helps secure those contracts. So think of us as sort of a group that goes out and brings physician-led primary care practices together and helps them enter and succeed in these value-based contracts. And the last thing we are is a very happy and active member of Emily's organization, National Association of ACOs.
Thank you, Sean. Since you've been there since the beginning of ACOs and at least in Medicare under the Medicare Shared Savings Program, could you tell everybody, for those less familiar, what is an accountable care organization and why have ACOs become such a central component of Medicare's value-based care strategy?
Sure. I think what you're referring to, me being there at the beginning, is I was at the beginning of the Innovation Center where we launched the first ACO model, which was then called Pioneer ACO. But this is a concept, well, in the broadest terms, this is a concept that's existed since Medicare started back in the mid-60s, which is dissatisfaction with a disorganized, uncoordinated healthcare system, and hope that there's a payment and delivery system model that would deliver better care at lower cost to Medicare beneficiaries. And you can think of it over time, both in population-based models like the HMO movement, which morphed over time into Medicare Advantage, but also other things. CMS has been doing pilot programs for many, many years trying to improve the quality of care. This all sort of coalesced around the ACO concept through a demonstration that CMS did called the physician group practice model, and that morphed into the concept of an ACO. And the notion is finding a group of providers who are willing to accept accountability for the total cost and quality experience that beneficiaries have. I think it's become an important part of CMS's strategy, and not just CMS's strategy, but Congress as well, because the notion of saving money by improving care is so much more attractive than all the other approaches to saving money for Medicare. The other approaches are reducing benefits, which very little of that happens in Medicare, cutting provider payments, which often happens, creating friction, prior authorization and other things for beneficiaries. So ACOs offer a third way that's really attractive in many ways, not just to the government, but to the providers who participate and succeed and to their patients who get better care.
Thanks, Sean. Emily, I'll turn to you if you have anything to add, but also could you tell our audience what the current ACO model is? What is REACH all about?
So, it's interesting. Sometimes we shorthand ACO for the payment models that Medicare offers, but we often think about, and our members are the O of the ACO, the organization, the network of providers. So just make a little bit of that distinction, because we will say ACO when we mean both, either or, the network of providers, or sometimes the actual contractor payment model that Medicare offers to those networks of providers. So just a little addition to that. In terms of what's available today, we have strong and robust participation in the Medicare Shared Savings Program, which sometimes people refer to as the permanent program, the program created in statute by the Affordable Care Act, and growing participation in innovation center models. So Sean mentioned the first of that, Pioneer ACO. I was leading a Pioneer ACO, the organization, one of the original 30 that participated, or 32 participated in that. And over time, those in true sort of demonstration, a sort of legacy demonstration and piloting innovation, as the name suggests, process, developing iterations on that. So what are the other benefits, waivers, payment models, downstream payments that you can add to that sort of original model that will, the thesis is improve clinical outcomes and financial accountability. So more affordable, better care. And that's what we see in the Innovation Center. You mentioned ACO REACH, which is the current ACO model out of the Innovation Center, and many of our members participate in that. And that offers some of those additional features of a little bit more flexibility on how you create the network, how you can flexibility in how you can deliver care, and then flexibility in how you pay providers, all within the thesis of with those flexibilities, you can improve care and reduce cost, in new and different ways, and hopefully better and more successful ways. So ACO REACH is coming to an end, and lots of activity right now, and getting ready for LEAD, the newest ACO model. So yep, REACH, lots of good experience from our members there, really some really good outcomes, particularly for some of the highest need population, the most clinically complex populations, and some new types of providers that weren't participating as much. We see in REACH and hopefully in LEAD, such as some of the more safety net providers, community health centers, and some of their state-based associations. So that's sort of what's going on in the ACO landscape. I know you want to dig further into some of those details, but maybe I'll just pause there.
We sure will. For now, you both come from different perspectives, and I wanted to take a moment to compare and contrast those perspectives. We're grateful that you both are here because you're truly both are really leaders in the field, and I can't think of two better people to have explain this to our audience. So, Emily, let's stick with you for just a minute. Can you tell us a bit about how large integrated health system ACO experiences, perspectives, and challenges may differ from those of the smaller ones? And then we'll have Sean, you do the reverse and talk about the physician-led ACOs and how those differ from the large integrated health systems. So Emily, we start with you.
Sure. So they're all physician-led. In fact, it is a requirement of the program. So just a little comment there on that term. And so, yep, when I moved to Trinity Health, I got some really good insight into how a health system, as the enablement or convener or aggregator of practices, can influence different points along the care continuum, how they approach managing total cost of care and pulling in, maybe a greater variety of providers than when I was doing that inside a medical group. I really enjoyed the medical groups I worked with. They had great success, and I used to sort of look across the river at the home hospital and say, gee, I wish they would work with us a little bit more on those preventing hospital admissions in the ED, and then when people are admitted, a little bit more work, take a minute to work on a transition plan that supports all the work my clinicians and providers were doing. And so I had that opportunity when I moved to Trinity Health to try and knit that all together. And so it was very satisfying from that perspective, being able to do more work before to try and prevent a hospitalization, and then a sort of extra touch before someone left to make sure they had a really strong transition plan. And the inclusion of specialists, community access points, other kinds of healthcare facilities. It's more complicated, right? All those relationships, trying to organize all that care. But what I saw was an investment in the long game, right? These are health systems generally, particularly those that are strong and engaged members of NACOs, as Trinity Health continues to be. They've been in these communities for over 100 years. This is the way they think is a more sustainable care delivery and payment model to improve the health of those communities they serve. So they take sort of a all in, everybody in. We're gonna get the whole community involved, and that's how we're gonna transform care. So a slightly different thesis, if you will, but with absolutely the same goal of better, more affordable healthcare.
Yeah, been a big admirer of the work Emily's done over the years, and starting long before she was the head of NACOs. Because as she said, hospital-based ACOs are somewhat different than independent primary care-based ACOs. They have some tools that we don't have, and vice versa. They have a little bit tougher economic model. And I think you saw that in the early days of the MSSP, the physician-based ACOs were performing better. But a number of health systems, including Emily's old health system, Trinity, and others, have figured this out and have done very well, which is heartening. Like, this is a model that works in a lot of different configurations, which I think is important for the future of Medicare and value-based care. But our particular approach generally starts with, as I said, independent primary care, which often can include federally qualified health centers. And you have to think of the normal plight of an independent primary care physician. They get the worst contract from the insurers, typically. So I'm talking about their general lifestyle. They can't really negotiate fee schedules with insurers. Their costs are going up, their fees are not going up. And they get caught in this life of churning patients, meaning, and we've all experienced this in our own lives, of spending less and less time with each patient so that they can see more patients and meet their rising costs. The nice thing about the ACO model is this turns it on their head and says, actually, the patients who are most difficult or most likely to be hospitalized are exactly the ones you should be spending time with. It provides an economic model for that, meaning by doing more primary care, more targeted at the most vulnerable beneficiaries, you're most likely to be successful in generating cost savings down the road. And so whether you're working with a hospital or out in independent primary care, that's very appealing to primary care physicians because it's how they hoped and were trained to practice. So that is our model. The reason I mentioned it's a tough economic model for hospitals is, one of the downstream effects, if you're successful at it, is fewer hospital admissions. Now, the smart hospitals have learned to adapt to that. And, when they have fewer admissions, they can either improve their market share and have fewer admissions per thousand, but just as many admissions, or they can reduce costs and generate higher margin. So one of the untold but really nice stories of MSSP is it's really unique in that a lot of different configurations of organizations can participate, work to their strengths, and succeed in the program.
Thanks, Sean. And let's stick with you for a minute. You already mentioned the Pioneer ACOs, but can you talk a little bit about what the difference is between the MSSP? For my understanding is it's actually a section in the Social Security Act, whereas the CMMI, the Innovation Center ACOs, have more flexibility. But if you could expand on that so people can understand what the difference is.
Sure. Well, the thinking at the beginning of the Innovation Center was we have this new statutory program, the Medicare Shared Savings Program, but it's new. It's based on a previous pilot, and there's a lot we don't know. So maybe we should be testing alternative policies, other ways of running the ACO program alongside it and improvising, and then taking lessons from the pilot and bringing them into the statutory program. So and I think that thought process has continued through multiple administrations. Emily referenced the lineage. There's always been an ACO model out of the Innovation Center. I think we're on our fourth. And some of the provisions that have worked well in the models have made their way into the statutory program. So that's one thing. Two, when an organization is trying to figure out, well, which is for me, which pathway is for me, the really threshold question is, how much uncertainty are you willing to deal with? Because the nature of a pilot or demo is that it's going to change. As lessons are learned, CMMI is going to make adjustments to the model. A fair amount of those adjustments will be favorable to the participants. Some participants might not perceive as favorable, like the government feels like they need to do something. So you really have to be prepared for uncertainty. And I mean, that's sort of who's gravitated toward it. Some of the more leading healthcare organizations in the country who are comfortable with that, comfortable with risk, have gravitated toward the more pilot programs. We are in an interesting time where LEAD, which Emily mentioned is the next model starting January, It will be for some of these leading organizations, but CMMI is also creating a pathway where it's trying to get organizations that have not been ACOs before, that are really the higher cost, more reluctant participants, non-participants around the country, trying to lure them into the ACO model through a variety of ways they've structured it. And I think that's a little bit different than how CMMI ACO models have been used in the past, and time will tell if it works.
Thanks. Emily, can you tell us, you mentioned LEAD earlier. Can you tell us a little bit about LEAD and how that differs from REACH?
Yeah, sure. And Sean touched a little bit on this in terms of sort of model design. Some of the most interesting changes that will have people take another look that maybe REACH was not a good fit for them. One is whole practice approach. So in ACO REACH, one of the sort of design features, and this was true also in the predecessor NextGen and Pioneer, you could create your network or the O of the ACO based on individual providers. So provider A, provider C, but not provider B. They might all be in the same practice. They might be all billing under the same tax ID, but you could select your network. That was a feature of innovation center models broadly. LEAD changes that, where it would take what we shorthand call the whole tin approach. So the tin is in. If provider A and provider B are in, C are in, so is B. So it's the whole tin. And unlike REACH, instead of there being different tracks for different population types and different ACO types, it's the whole practice, it's the whole patient population with some features that support a care model designed for some of those more complex or higher need patients that was so successful in REACH. So it takes that full practice, full sort of medical group approach, which is what many of our members like. It means they don't have to choose. I can have these providers in, but that leaves these providers out in one medical group. That's not awesome. And so this way, the whole practice is in. So that's very different for an innovation center model. And one of the reasons why more people are looking at LEAD, because that's the way MSSP is also organized, as that whole tin approach. So now you have a design feature that is the same in both. That makes for folks who may have wanted to stay in MSSP, take a look at LEAD, and those who have been in REACH need to think about a different configuration of their network in LEAD. So some really sort of interesting considerations with that. And then, as Sean said, folks who maybe were in an ACO in early years and then out, or who have never saw it as a model that would work for them. There are design features in LEAD specifically to have historically high cost, historically sort of safety net, rural, some of those entities or organizations, at least the way it's designed, they have a pathway, they have a good reason to take a look at LEAD and see if it works for them. So that deadline for applications is passed, and I think almost all of our members applied simply so they could then evaluate that option for 2027 and look at both models. So way more applications I expect we will see than we've seen for any other innovation center model, partly because of those design elements that I mentioned.
Jim, one of the issues I wanted to follow up on is, and this notion of organizations that have joined and left MSSP or never joined. One of the things we say at Alidate, like we have national scope. We're talking to practices all around the country. So in addition to having a lot of practices say yes and join our ACOs, we have far more practices that say no to us and don't join, not just with us, but don't join with anybody. So one of the questions CMS has been asking, and we've turned around and asked ourselves, why do some people not join? It's a successful program. Our practices are doing much better financially because of the program. We look to, there's a literature around tech, if you use the analogy of technology adoption, of early adopters, late adopters, mainstream. And one of the main lessons from that literature is the people who join early there's something fundamentally different about them than the people who don't join early. Think of your friend who was the first to get an electric car. I don't have an electric car yet. I assume someday I will once I realize it's the normal thing to do. So we've been trying to look through the future in that lens. Like, what is different about the people who've been sitting on the sidelines and haven't joined MSSP yet, and value-based care generally? And one of the lessons is they want to join something that's considered the norm. Like the innovation sort of scares them, and the uncertainty of a model. They want a program that is a program that's expected, that feels comfortable clinically, that is good for their patients. So this is, as I mentioned, LEAD has a lot of attractive features if you've never been in the program. And we can walk through them. They reduce the discount. They offer some upfront money. There's really a lot of cool stuff that CMMI's put in there. One of the things that worries me is that just the word innovation and that this is a temporary model might not be the right place for these folks to start. Or I'm worried that's how they will interpret it. It might very well be the right place for them to start. But one of the things, MSSP sort of plateaued in participation in the last 5 or 6 years. Actually, 2026, we had a nice tick up, but prior to that, it had been fairly flat. So one of the things the policymakers are looking at, I'm sure Emily's thinking about for her membership, and we've been thinking about for our ACOs, is how to get those folks who've been sitting on the sideline to participate. One of the things we've done collectively is a really nice track record of success, and hopefully over time, that'll be part of convincing these practices.
Thanks, Sean. On LEAD, the applications were already due, but there's some details left to be worked out in the program. Can you talk about some of those details that are left to be worked out in the LEAD program and how that might affect an applicant's decision to if they have the opportunity to join LEAD, to actually join it, or could they decline the opportunity to join LEAD and switch back to the MSSP if they don't like how these unanswered questions are answered ultimately?
Yeah, so right, I would say most of our members are running parallel tracks right now. They are maybe already in MSSP, or they've applied for MSSP and LEAD, because the timing of how those details that you mentioned, those details develop is such that you need to have applied, so that when what I refer to as the math paper, the methodology detail comes out, which is over the summer, so that could be soon, you have an opportunity then to sort of run the math, you have a network of providers that you've already thought about because you've submitted an application. And the question is, of those design elements, as those show up in math, how does that work for you? So we talked about earlier that sort of whole practice. So if you were in reach with a select number of providers, what would it mean to be in LEAD with the whole 10 or the whole practice? So you got to do that math. And then you have probably a sort of hypothesis around what some of the other features in LEAD, how those will help you be successful, whether it's being able to create downstream payment models, not just for primary care, but for some of those other groups that they've designed, pre-designed some payment models for. So you want to see the math and some of those details as well. So things that are that are design elements that look attractive, you need to see the math behind that and how it all comes together to really make that informed decision about what's going to be the right model. There are some things that are not going to be a part of 2027 that will come later. So there's an opportunity for integration of Medicaid into states. There's some piloting of a different risk adjustment model. There's some future benchmarking features. So nobody will know that over the summer, but so that will continue. Those elements that we see in design will continue to move into implementation over the the time of the model. Sean, what would you add?
Yeah, actually, you touched on it at the end, which is, there's the uncertainty right now that'll, some of which will be cleared up, as you said, when the financial documents come out. And we'll all have to, I think the drop dead is early August, like where you really got to throw your chips in one program or the other, or get out altogether. But even more interesting is they've forecasted, as you said, on risk adjustment, on benchmarking, on a couple of really fundamental areas that they fully plan to make substantial changes maybe 4 or 5 years down the line. As a policy nerd and someone who's worked on some of these things, it's really exciting, some of the stuff they're talking about. But if you're an ACO if you're a group of providers never been an ACO, the notion that the rules might change fundamentally in 5 years is sort of maybe a little daunting or a little exciting. I don't know. We'll have to find out.
Thank you. From some of the providers we've worked with, we've heard that their reason for not continuing with ACOs has been related to the stability of the program, that, mid-program, the targets change, the program, they make a big investment up at the beginning of the program, then the program ends, or they change it and it's no longer, their investment it doesn't bear out. So it's better just to sit on the sidelines and deal with original Medicare fee for service. Let's go with you, Sean, first. Like, what would you say to those people, and what's being done to address the concerns about stability of the ACO models?
Yeah, I think that criticism that you mentioned, it has been directed at the innovation center models because they are subject to some uncertainty, whether they'll continue, whether there'll be a smooth transition to something else. CMMI did try to address that head on this time by declaring up front that the lead model will be a 10-year model, which I think is very important. It's not a guarantee, unfortunately. They can't guarantee that something will run for 10 years, but I think it's an important statement of intent, and that they're hearing the same message that you were hearing, which is that that's really problematic to people. This is less true of the Medicare Shared Savings Program. It has not gone away, and it is a permanent part of the Medicare program. Where we see opportunity to improve things on the permanent side, the Medicare Shared Savings Program, is through what we call getting rid of ratchets and rebasing. So essentially, successful ACOs periodically have to have their benchmarks reset, and in that process often lose a lot of the savings they've built up over time. The problem with that, so we have, for example, an ACO in Louisiana that's been in the program 12 years, ran a number of years with zero savings, slowly got good at it, and then got up to like 17% savings, goes through rebasing, and that's coming crashing down to like 4%. And the problem there is that ACO, I mean, the shared savings are the revenue that they reinvest in these care management strategies and all the good stuff that ACOs do, and have that money periodically dramatically drop, not because the ACO didn't perform, they performed even better that year, but because CMS is periodically rebasing is an opportunity we should be smoothing that out. We should be creating, if ACOs perform, we should be creating a pathway for them to have an ongoing stream of revenue that's somewhat predictable. Now, I'm not saying free money, like it has to be based on performance. So those are the sorts of opportunities, I think, to really make the Medicare Shared Savings Program more attractive, as opposed to CMMI, where people are more worried about the transitory nature of it.
Emily, anything to add there?
I think that was really well said. And back to Sean's earlier point about if change is hard for your organization to manage, and maybe you're not part of NACOS and someone who's in there to make those changes, good changes, hopefully, then you want to be in the permanent program, but that comes with less frequent responses to the things you want, right? So it's a little bit of a trade-off to go through rulemaking to address as needs to be addressed. And I think there's general agreement we need to address that rebasing or ratchet effect, both for individual ACOs who are now some in their third agreement period. So like they already took a hit once and they're facing or just taking a second hit. It just doesn't make sense to keep investing if that money's going to be sort of what feels like pulled out from under you, even though you see it there, but then you actually feel it when you recontract. So that's an important element, not just for those individual ACOs, but as we have hit the point where most Medicare beneficiaries that are not in Medicare Advantage are now in an ACO. So just went over that line. Now we're decreasing costs for the Medicare program broadly. And so we also need to make sure that as we do that, we preserve the value of the savings that ACOs have contributed to the overall decrease in the decrease in the acceleration of costs really is what we're talking about. So both at this point in the sort of program's history, it's both solving that for the individual ACOs who feel it the most strongly and will make participation decisions based on that. And then for the sustainability of the program as a whole, particularly for those who in the early days said, well, I don't know about this ACO thing. Is that going to survive? Is that going to survive the sort of first administration? Well, yes, in fact, it has survived now a number of administrations with that continued commitment to have 100% of Medicare beneficiaries in an accountable care model. And so that sends a strong message, and then some of the features that Sean mentioned. But we still got to fix what is now showing up in implementation. Some of those, basically the rebasing and ratchet effect.
Thanks, Emily. And Sean, just one more question before we move on to the next topic. Why not just, if people were happy with REACH and that they succeeded at that, why not just extend REACH and then make LEAD a new option if people in REACH wanted to switch to LEAD, or if other people that LEAD appealed to, but you've already got the REACH people as an ACO in a program, why risk losing them by making them choose LEAD, MSSP, or nothing?
That's a great sort of foundational question. And it goes back to the statute that created CMMI, which is CMMI tests new payment and service delivery models. And these are temporary tests unless CMS can certify that the model is either saving money and not hurting quality, or improving quality and not spending more money than it otherwise would. CMS's evaluations of the REACH model had found many positive aspects of what was going on, but did not document savings to the government. So I think the current administration felt a statutory obligation not to continue the model. I would note under the statute, they had an alternative to modify the model, but I think they wanted to start from scratch and try something new. And I think they thought that in creating LEAD, they created a pretty smooth pathway for the REACHs to continue, that they don't have to make fundamental changes to stay in. But I think it goes back to that all CMMI models have to pass this actuarial test of whether they're actually saving money. And this one, it apparently was not.
Thanks, Sean. So One of the things that I don't get to say very often, but excites me about ACOs is both Republicans and Democrats agree that ACOs are a permanent part of the Medicare program, not just because it's in statute, but both, well, all of the Obama, first Trump, Biden, and now second Trump have continued to promulgate ACO models through the Innovation Center, as well as continue the Medicare Shared Savings Program. On the one side, why have ACOs been so successful? And then on the other side, how have the approaches of the administrations differed in their management and implementation of the ACO programs? So let's start with you, Emily, and then we'll go to Sean.
To perhaps oversimplify, but why these programs are successful is because the payment model better supports the care delivery model that primary care would do every day if that's what was paid for. So, I mean, just fundamentally, having spent most of my career with primary care providers, they would just say, this just makes more sense. I want to know about, I had one doc say, I'm not worried about the people I'm seeing today. We were doing sort of pre-visit planning and some of those good like ACO type activities. She said, I'm worried about the people I'm not seeing. Who's looking at those people and seeing, is it because they missed an appointment? Is it because something happened and they got admitted to the hospital? Like, who's not on my schedule worries me more. And so these models give you insights into the total patient population, all the care that they're receiving. They enable you to design true patient-centered care plans, reach out, give you incentive to reach out to people between visits, before visits, do all that good stuff that better aligns with the way a primary care team would want to practice. So fundamentally, I think it is that better match of payment with care delivery, and just it's trite, but you get what you pay for. And so this pays for something better. So you get something better. You get better outcomes, you get lower cost, and ACOs deliver on that all the time. And so that it is an incredible program, as you say. It has been successful. It is highly supported across multiple administrations. They may have a slightly different thesis about how to get to that endpoint, but we deliver results, and so why mess with success?
Sean, can you talk a little bit about the different approaches of the different administrations to ACOs?
Sure. And just to be the third person to say this, like it is every administration. If anything, the thing they're not content with is how do we get more people in this program? Not like, oh, we'll let it continue or we'll continue testing, but we want more people in ACOs. Chris Klomp, who's the director of the Center for Medicare and has jurisdiction over the Medicare Shared Savings Program, was on a podcast recently. He said, accountable care outperforms unmanaged fee-for-service on every measure that we follow. Like, I need more of that for our beneficiaries. So couldn't have a stronger statement of support than that. The differences really come down to nuance. So like I said, like everybody's wanted more participation, everybody's wanted more savings. So for example, the Biden administration would have had also put some policies in trying to look at equity, health equity, or any populations being left behind. Could we incentivize better care for those? Both Trump 1 really pushed more for a faster movement to downside risk for ACOs. So, and even that, like every administration has to calibrate, because remember, this is a voluntary program. So like you can't force people to take downside risk, they'll go. But trying to, put the thumb on the scale to move people to risk faster. This second Trump administration, there's been great rhetoric. We now have the LEAD model, which is a very important statement of what they're interested in. Longer model, getting new participants in, trying a lot of different things. What we haven't seen, but we'll see in the weeks coming up, is what they do in the Medicare Shared Savings Program, where their priorities are there. They've made it clear they want it to grow and they want more savings, but what their approach to doing that is, we'll see probably in early July sometime when the proposed rule for next year's Medicare Shared Savings Program comes out.
Thanks. And we haven't talked much about it, but I want to get at least one question in. Like we talk about, getting paid for better health outcomes or keeping the same and less money. How are the outcomes, or is quality measured as part of the value equation for ACOs?
Sure. So it's a combination of your sort of classic HEDIS measures, right? Are you doing a good job managing patients with hypertension? Right? Are they on the right sort of clinical protocols, and is their blood pressure in control, as we might say, right? So those sort of classic HEDIS measures. And it's a Medicare population, so it's a lot around management of chronic disease. Then there's a set of utilization measures, right? If we're doing a good job, we should be lowering preventable ED visits, hospitalizations, readmissions, all those things that better management in the community in advance of an exacerbation of an illness. We do a good job at that. So we should be performing on those utilization measures. And then thirdly, patient experience, right? So are we improving not just the clinical and financial outcomes, but the experience of care, access, connection to specialists, help with medication? So those, some of those sort of classic patient experience or CAPS measures. So it's a combination of those. And interestingly, going back to our conversation about LEAD, one of the differences between REACH and LEAD is LEAD is adding back some of those clinical HEDIS type measures that were not present in REACH. So there's just another difference.
Emily did a great job covering what we're measuring. There's significant changes going on of how CMS is measuring, and it's this movement to what are called ECQMs, or electronic clinical quality measures. And that has been a little bumpy because, the certified EHR technology, my sense is, if you're unified, like if you're one health system and all your ACO participants are on the same EHR, that'll generate these ECQMs more readily. Our situation is, in one of our ACOs, we could have practices on 20 or 30 different EHRs. And the technology of aggregating that and normalizing it isn't where it's supposed to be. So I just wanted to flag that I think CMS has focused on the right measures, but we are concerned about their rapid movement to what these things called ECQMs and whether the technology is where they think it is.
Sean, in your opinion, are we measuring value in the right way, and or are there improvements that could be made to how we define what value is? Like right now they have these quality measures that lists of hundreds and hundreds of consensus-based developed measures that are largely abstracted from claims data. But is that the best way or the right way, or is it just what we have available, so we're using it?
I think Emily's right. I think the focus on these chronic care measures is appropriate. I do think we're measuring too many things. Like if everything's important, then nothing's important. I think there's probably a couple, diabetes, hypertension, there's probably a couple core areas that if we really focused on, one, we could measure it really well, and two, we'd get more improvement. But also, let's step back and remember, why are we measuring quality in the first place? One of the reasons in the Medicare Shared Savings Program was the fear that there would be stinting, like ACOs would generate savings by denying people care. But we now have 12 plus years of proof that that just isn't happening. Like the way to be successful is by doing the opposite. wrapping your arms around the sickest patients with better primary care and better management of these patients with multiple chronic diseases. So I think some of the impetus for measuring everything under the sun has dissipated. It was understandable when this was new and untested and we were worried. And a lot of this quality measurement could go in the back, behind the scenes as sort of monitoring, make sure that never does happen. But as far as incentivizing performance, let's focus on the really key chronic diseases that these primary care docs are best situated to generate results for. The last thing I'll say is there's a great paper written by the former CDC director, Tom Frieden, and my boss at Aledade, Farzad Mostashari, that said, if your sole goal in the healthcare was to save the most lives in American healthcare, what would you do if you're really just trying to save lives? And the data showed the answer was control high blood pressure, focus on hypertension. And I'm not sure we're putting as much attention on that as the potential it has to improve the lives of Medicare beneficiaries deserves.
That's a good promo. One of my pet sort of issues is high blood pressure is such a big problem in Medicare, but DME does not cover a blood pressure cuff to send home with a patient when they get diagnosed with high blood pressure. So I bet that's one of the key things ACOs make available to people with hypertension is a way to check their blood pressure at home.
Well, I'll return to high blood pressure in a second, but there's a theme there that's really important to the ACO movement, which is so many Medicare payment rules, all the ones I used to help administer and maybe even stronger and tighter, are focused on a fee-for-service environment of how do we prevent overutilization or abuse of this benefit of this service of this billing code. And it's all focused on not allowing overutilization. But when you flip the switch, now you're in an ACO environment. A lot of those rules just don't make sense anymore, right? You're not worried about overutilization because someone's accountable for total cost of care. And now a lot of those billing rules become impediments. Earlier in today's discussion, Emily mentioned something about waivers, and CMS has been incrementally giving some waivers. Telehealth, like ACOs had telehealth waivers long before COVID made them ubiquitous. I think there's a lot more we could do in the ACO space of loosening those payment restrictions. And you're right, the ACOs have quite a few are providing blood pressure cuffs. I think you'll see even more of that in the new, we haven't talked about CMS as something called an access model, that one area of focus will be hypertension. So, but yeah, like there's a lot we can do, and the ACO environment makes it, I think, safer for CMS to experiment.
So we're just about out of time, but I want to wrap up with Emily, is there anything that we could learn from Medicare Advantage that could be applied to ACOs in the lead or future models?
Yeah, so just picking up on Sean's last point, what in Medicare people would refer to as VBID or value-based insurance design, some of those sort of tests of being able to add to a benefit, a package of benefits, things like sending home a blood pressure cuff with somebody. So that thinking around how to provide benefits, we might call them beneficiary enhancements or waivers in an ACO program. But the thinking is, what can we do to make it easier for people to get the care that we know improves clinical outcomes and reduces costs? So we do see that sort of pickup of some of those tests in MA, and not exactly a one-for-one, but the same kind of approach around testing additional benefits in the ACO. So that's a pickup. The other is, in ACO, if you put an ACO in the middle between traditional Medicare fee-for-service without an ACO and Medicare Advantage, what you have is trying to get to a more known population and a more integrated network, right? So if you think of MA, people are signing up. I want that MA plan and with these providers, right? So a very well-known population for a provider group to manage and a very well-known network. And an ACO gets you part way there. And so some of the additional elements that help individual Medicare beneficiary understand what this is and be able to raise their hand and say, that's good stuff, I want that. It's more like an enrollment. It's called voluntary alignment in the ACO, but it's more like being able to say, I want to positively elect to be part of that. So there's a feature that our members want, we're advocating for, and CMS is trying to figure out how to offer that as a better pathway. So that's sort of to help people understand what the models are and raise their hand and say, I want to be part of that. And the other is a little bit more, since we can see patterns of care and providers when we identify fraud, waste, and abuse, which we do, our members do. They go out and knock on the doors of, this provider that's actually a post office express. That's clearly fraud. And for us to be able to identify and put the kibosh on that. So MA obviously has a lot more ability to do that than we do, but ACOs have gotten more involved in that space, working more closely with the Office of Program Integrity to identify and stop some of that abuse in Medicare.
And Sean, rural is hot right now. There's been a lot of emphasis on rural areas. Can ACOs succeed in rural areas? And what has been Alade's experience in trying to reach out to rural areas?
They can absolutely succeed in rural areas. In fact, a big part of our network is in rural areas. Because if you think, we primarily work with independent primary care practices, and rural areas is one of the places where they're still pretty frequently found. And most of the metro areas are, more consolidated into health systems. That's another approach. But if you're looking for independent primary care, you're usually looking from the suburbs out to rural areas. Our rural ACOs have done terrifically well. I think they face somewhat accentuated challenges around just they need support just to exist. Like if they're waiting 18, 24 months for the first shared savings check, I think they're all in dire straits financially. And so more of the upfront help that CMS has periodically offered to ACOs is important. But also, and this gets a little technical, these things we call ratchets. Part of how an ACO's benchmark is established is compare an ACO's cost trend to its local community. But if you're in a rural county, your local community might be largely your beneficiary. So as you're reducing the rate of growth cost, you're also bringing down your benchmark. And this has been a long-standing problem in the Medicare Shared Savings Program that multiple administrations have been tinkering with and trying to fix. And I still think we have a ways to go to fix it, but that works against rural ACOs. But the good news is, yes, they can and are succeeding quite well.
Great. Well, thank you both. I'd like to finish with a final question, same one to both of you. What is the one thing that you'd like our audience to remember from our discussion today? And let's go with you, Emily, and then we'll let Sean have the final word.
So if you think an ACO was not for you, take another look. There are a bunch of design elements in the new model, and we should see over the summer improvements to the permanent program, and all of that should do a good job at bringing in some folks who are not participating today.
And Sean, what's your one thing?
I say mine in the context as a follow-up to Emily's, which is, and if you're worried about, whether this is the program for you, understand it is a permanent part of the Medicare program that's enjoyed bipartisan support across multiple administrations, and in fact is a particular strategy that administrations have been trying to grow. So if you elect to participate, you're joining a growing wave, and you're going with the tide, I think, of future policymaking.
Great. Well, thank you both. That brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Sean and Emily, for sharing your knowledge and insights on ACOs. Before I close, we just sent a message in chat with links to subscribe to our monthly newsletter for more in-depth insights into current and perhaps future health policy. Thank you for being with us and enjoy your day.